And we're back. We have Scott Greenberg. Scott, this is your first time on. For people who aren't familiar with you, can you tell us a little bit about yourself?
Sure. Well, first of all, thank you very much for having me. Honor, privilege to be on here with you guys. So Scott Greenberg, been a PT since 1999, primarily in the area of sports physical therapy. I reside currently and have for the majority of my career here at the University of Florida Health System. Prior to that, I'm New York born and raised, as we talked a little bit about before I stepped on. Came down to Florida and I was hooked. I wasn't going anywhere. So decided to stick my roots in the ground here. Been at University of Florida since 2002, which means I'm pretty old, and pretty much involved with sports medicine. Like I said, I've been a standard staff clinician. I've managed one clinic to multiple clinics. Now my title is manager of operations for our entire outpatient rehab department. What that means is, we have PTs, OT, speech on board. But the most fun part of my job is I direct our sports and orthopedic residency programs. So that's been a fun. It's not much fun now as we're getting ready for reaccreditation. So there's a lot of stuff that goes into that. But generally speaking, it's a lot of fun. The other fun part of my job, I'd say, is I'm the physical therapist or one of the physical therapists for Florida Gator Athletics. So the only patients I currently see right now are the Florida Gator athletes, with a really an area of emphasis for me on the lower extremity and specifically foot and ankle, foot orthoses. I do some knees, and I have obviously over the course of my career treated shoulders and hips and backs and all that good stuff. But as I've kind of gotten down to kind of this dual role of administration as well as patient care, I've been able to niche in a little bit more and really running mechanics and foot and ankle has been my bread and butter for a while.
Hence why I brought you on for what we're going to chat about today, all things Achilles tendon rupture, conservative rehab versus surgical, and what this process looks like. You've been on previous podcasts. You were on Noah Mandel's podcast, Forward Physio, which was awesome. I know you did I think a physio, was it Physio Tutors or one of the other continuing ed websites? You did a Achilles tendon rupture physio network. Yeah, I think that was a gymnast. I remember watching that one and really enjoying it. So you've been on different platforms, but we want to share this on our E3 podcast, and I think it's going to be a great conversation. So we're going to start really from the beginning. Someone's just ruptured their Achilles tendon. What are the factors to consider or driving someone to make the decision for surgical management and post-operative rehab and non-surgical management and rehab?
Sure. And then really it's a $1 million question. And depending on who you ask, you may hear some different answers here. My patient population is pretty much right now between the ages of 18 and 25, 26. When I start to deal with some of the professional athletes that kind of come through my door, 35, maybe about the max age. But with most sports situations, you're going to want to deal with that traditionally surgically. You can be a little bit more aggressive early on. There are numerous studies out there that show that by like 12 months, the deficits side to side aren't really that significant. But if you're thinking about the athlete and getting them back as quick as you can, which again, in my world is one of the key things that we strive to do safely, of course, surgical options are usually the avenue taken. They give the athlete a little bit more reassurance, and the coaches too a little bit more reassurance that when you go in there and go to get it taken care of, it's going to be taken care of, as opposed to kind of trying to approximate that tissue. We'll call it in a conservative manner by really casting them or bracing them in a plantar flex position for prolonged periods of time, and then hoping that there's enough blood flow and such to kind of heal the tissue and allow it to kind of gain that stability and stiffness that you need. But I'd say in my patient population these days, in an athletic population, surgical options are typically the way to go. The other thing to really think about, again, age, not only with, between them being an athlete, but the older person is typically not going to put the tissue through as great demand. So the actual strength of that tissue may not need to be at the level of, say, a gymnast, for example, who's going to need to load and explode off that tendon and really relies heavily on the elastic and explosive properties of that tendon. And then probably the most important thing in treating it conservatively, non-operatively, if that's the way you want it to go, is catching it early and getting them in that plantar flex position as quickly as possible. I'd say within the first 24 to 48 hours, you want that thing locked up in plantar flexion and staying in that position for a good long time to allow that approximation to occur more naturally.
Yeah, you just touched on it, but let's say someone is a few days out from the rupture. They have maybe already made their decision of, okay, I'm going the surgical route, but I have to wait a week, 2 weeks, a month, whatever it is, or they're going the non-surgical route. I'm sure before the surgery, the priorities are still the same. Like you said, putting that foot and ankle in as much plantar flexion as possible. What other things are you discussing and trying to create as a really beneficial starting point? Are they non-weight bearing? How much plantar flexion? What are all the things clinicians and patients should consider?
Those are great questions. And to be honest with you, nobody's ever asked me that question before. So that's a good one. I like it. I think you want to minimize that we'll call it retraction of the two ends of the tendon, right? You don't want to make that surgeon go digging through your lower leg and your calf trying to find the other end of that tendon. So I think minimizing the things that put that calf and that gastrocnemius complex or engaging that or trying to engage that are super important. Getting them in that plantar flex position again as quick as you possibly can, I think is really going to help. Keeping them off it, I'd say early on, especially if you're going to treat them non-operatively, is probably a good idea. There's a lot of studies out there that show early weight bearing being very, very helpful. But I tend to do that more with the operative situations. In the non-op situations, they tend to be casted in that plantar flex position where, again, it's if anything, it's just touchdown for balance, and just really letting time do what it's in the body do what it's supposed to do there. So I'd say that the keys would be similar. Is that you want to get them plantar flex, get them off it, get them to rest it, and then try to minimize that retraction of that tissue as much as possible.
Yeah, that leads into just the general early stage rehab priorities. And I want to differentiate the differences in your mind of the operative early stage priorities, and we can use this 0 to 4, 0 to 8 week timeline, and then the non-operative priorities you kind of alluded to maybe being a little bit more kind of quote unquote aggressive. I'm sure that's a relative term, operative versus non-operative. But what are the things these first 0 to 4, 0 to 8 weeks that are similar and are different for surgical and non-surgical management?
Yeah, so from the standpoint of surgical management, the things and surgical versus non-surgical or non-operative, the big difference and the big concern early on in the acute stage is getting that wound to heal, right? Infection, wound closure. When I talk about Achilles repairs, I break it down into three main categories or three main priorities. We'll say the first one is you got to get the tissue to heal, right? You want to limit infection, get that tissue to heal. That tissue on the back part of that heel and Achilles region is really, really super thin and can be extremely problematic if, in fact, that tissue doesn't close. Then you start walking down the lines of, not only infection, but maybe the need for some type of skin grafting to allow that closure to occur. And infection, throws everything, timelines out the window if that occurs, right? So first and foremost, that's your biggest priority. Get that wound to close, make sure it's clean and dry and all that good stuff there. So that's number one. Second part for me is really minimizing the excessive or the unnecessary elongation of the tendon, the creep of the tendon, right? And we can get into this as we talk through this conversation, but limiting the unnecessary creep of the tendon, super, super critical in my population of an young athletic population. As you get a little older and maybe you're not necessarily requiring the amount of explosiveness that you need, and we could talk a little bit about Aaron Rodgers and his situation if you wanted to, and what his, maybe thought process was. And again, I'm not him. I'm not in his head. I'm not one of his physical therapists, but we could talk about some of the risks and benefits to the route that he chose. And then lastly is just get stronger, right? I'm a big believer in we'll call it the Rob Panarella / Al Vermeil pyramid of, you've got to get movement, then you've got to get yourself strong, then you've got to get yourself powerful, then you've got to get yourself more elastic, and then you can start to develop speed. But the foundation, aside from the movement aspect, in order to move well, you can't be strong if you're not strong through a full range of motion, right? So getting that motion to be as full as you can, mobility always before stability. So get your motion back, and again, in a protected manner in the case of an Achilles repair, right? We're not saying get full range of motion as quick as you can. You get the motion back through the restraints of the tissue and the surgery, and then you get yourself strong through that range. You build up a great base, and then you get powerful and you get more elastic, and then you get really faster at the end goal. But you can't be fast and you can't be powerful without that baseline strength. So those are my three big buckets, I'll say: wound healing, avoid excessive stretching, and then get stronger. Those are the big keys. In terms of how that differs in the non-operative situation, like your initial question was, obviously you don't have to worry about the tissue approximation and the infection component of it, right? So then you're starting to work on the tissue creep and the strength of the gastrocsoleus complex and the strength of the tendon, right? So those areas are the same. When I might initiate the actual progression of my strength is going to be a little bit slower for me in my hands if I go the non-operative route versus the operative route. And if you start thinking about what type of operative procedure they had, you can also start to grade how aggressive you can or should be. There are different procedures out there now where it's the peri-open or peri-articular, almost like a mini open type of procedure. Whether it's the pars or another one of the various type of jigs that they use to kind of suture those two ends together. And then there's the internal bracing, which is more like the speed bridge, in which you're taking it and actually attaching and securing the proximal end of the Achilles tendon longitudinally down in the same fiber direction as the normal fibers would travel, and then bone plunking it into the heel. That's going to give you probably the strongest repair, coupled with a pars, let's say, in which it's called the knotless repair. Oftentimes, is when you're taking the proximal end and the distal end, and you go horizontally through the proximal end, and you go horizontally through the distal end. Take the tails out on either side and actually tie the tails together and bring those tissues together. And there's some different patterns that you can actually sew through each proximal and distal portion of the tendon. But the bottom line is that you're not taking a traditional open repair where you've got a really knotted, nasty, exploded end of a tendon, taking the other end of crab meat tendon, sewing them together and creating this big knot bulbous type of repair. Back in the day when we used to start doing this, you used to get in there and you used to be able to do soft tissue mobilization, and you'd feel this big knot of just mass. And that was actually good. It was actually the tissue and the scarring and everything else to create that nice healing to kind of give you that security. But now if you start doing, that soft tissue mobilization, you'll see that those tendons actually are a lot, we'll call them, they're a lot cleaner in terms of their setup. They're a lot more in line with the fibers. And you don't have that massive amount of scarring that's taking place. But yeah, it's the thing I've noticed also with some of and I'm going to digress here a little bit, but the speed bridge repairs is that you're actually creating an area of irritation that's maybe not necessary in a lot of cases. With those two bone plugs going into the heel, I have found that you're creating some soreness in a post-operative repair that generally is not a very painful post-operative situation. There's just so much going on in that heel region, whether it be the periosteum, whether it be the bursa. There's a lot of things going on. And just like insertional Achilles tendinopathies tend to be more difficult for me to deal with than non-insertional Achilles tendinopathies, you're almost creating this irritation at that distal insertion point that probably isn't always necessary. I have a surgeon that doesn't do speed bridges, for this particular reason.
The two priorities outside of the operative, making sure that there's wound healing and closure. For operative and non-operative, it's getting that tendon and surrounding region strong and minimizing creep and elongation of the tendon. Those are two concerns for the patient and for the clinician. And I think a lot of clinicians end up trying to figure out, well, how much loading do I place into this tendon over the first 4 to 8 weeks, and where do I start? And then how quickly or how slowly do I slowly remove the wedges or increase some of that dorsiflexion? And I know a lot of that can come from the surgeon's recommendations, but what are
Yes.
those two things that um, minimizing creep and elongation of the tendon and strengthening that area, where do you generally start, and what is your progression strategy for both of those?
Yeah, great questions again. So I'd say I like to start isometrically um, in a very, very plantar flex position very early on. 2.5, 3 weeks I'll start. Again, once I'm really happy with how the wound is closed and things are looking good, I don't see any signs of infection or redness. If they're in a post-op splint, wait till they get out of that post-op splint. Usually get put in a boot in that plantar flex position with multiple heel lifts in the bottom of it. The traditional thing that you see. I will sometimes take them out of the boot to do isometrics. I know other of my colleagues will keep them in the boot while they're doing isometrics. I like to get them out. This way I can kind of gauge how much force they're putting through my hand as a gauge. And again, there's no way that they're going to create enough force, especially at end range plantar flexion, to do any damage to that tendon. If in fact the tendon was put together well, right? A crappy surgery, all bets are off. But if you've got good approximation and good suture closure, you're not going to be able to generate enough force in your gastroc soleus to really pull any significant amount of load through that tendon to do damage. But you are going to start to stimulate some of those fibers, which is again a very, very healthy thing to start to initiate that stiffening process. There are studies out there that show significant calf atrophy and gastroc soleus atrophy after being in a walking boot for like 8 to 10 days. Some significant, like 20 to 25%, something along those lines. So it goes fast. So anything you can do to minimize that is super big. I'm a big fan early on, even day one post-op, getting BFR on the contralateral side and doing some things to hopefully maybe get some systemic effects of the blood flow restriction therapy. So I'll do that really, really early on. Once I'm happy with the wound closure and the swelling's kind of under control, maybe even at like the 2-week mark, I might even start some BFR on the involved side, doing things like leg extensions, straight leg raises, hamstring curls, just to kind of make sure that those tissues don't atrophy more than they really should. And at the same time, starting to look at some of the big muscle involvement so that you can generate a greater hormonal response to maybe get some overflow into the gastroc soleus complex, which is, again, distal to those larger muscles, which, again, I think you're going to see some greater benefit from utilization of the BFR. And then I'll use BFR even doing some of the isometric stuff when they're out of the boot, keeping them, again, very much engaged in a plantar flex position. So those are some of my tricks that I do there. I really, with regards to your second question and avoiding creep, I am very, very anti, and I have a pretty hard stance on this, and I'm probably more conservative here than a lot of people are. I usually don't like to get my hands on my patients and stretch them into dorsiflexion unless I really need to at about the 5 or 6 month mark. Now, that doesn't mean that dorsiflexion isn't important. It absolutely is. And it doesn't mean that I don't get my hands on my patient and maybe do some soft tissue mobilization to their calf or do some talocrural joint mobilizations in the interim. But I feel they're gonna get the majority of their dorsiflexion back by doing things like step ups as part of their therapeutic exercise program, heel taps as part of their therapeutic exercise program. But for me to get my hands on them and start cranking them into dorsiflexion, I just feel is really, really unnecessary. And I'd much rather it come back naturally doing their normal functional activities of daily living. But again, if I do see it's really starting to lag behind and they're getting excessively stiff, that would be something I would do. But that would be a last ditch effort for me. And I haven't had that issue really in my years of doing it.
Going back to the starting point of isometrics, you said maybe as soon as 2.5, 3 weeks. What does that specifically look like? You said manual pressure. Are you having them in long sitting and you're just having them plantar flex down into your hand? Are they feet on the floor with some wedge support and you're pushing down? Where's that starting point? And then how would you progress those isometrics?
So another good question. I like to sit them. I first start them seated, knees at 90. So you're kind of taking the gastroc and you're kind of shortening it some. So you're not necessarily, putting that same tension through it. start them in that position, whether they're sitting in a chair and they're wedged and pushing down into the ground. That's fine. Or doing some manual pressure if the table's too high and they can't get their foot to the ground, making sure that they're staying in that plantar flex position while they're giving a little bit of that downward pressure. That's fine too. Progressing to a more extended knee position as time goes on. And again, that can be fairly quick too. I don't have to go crazy with that. It could be within, the from the 2 week when you start initiating it in a seated fashion, knees at 90, hips at 90, let's say, to more of a long sit position. That could be maybe at the 4 week mark. I'd maybe start doing it in that position. And then you can increase the intensity too, right? You can start increasing intensity. We start TheraBand stuff relatively early as well, keeping them dorsiflexion no greater than neutral. So as long as we're keeping them in that neutral to full plantar flexion range and not going beyond that, I think we're in a safe range too. And again, TheraBand is so light, especially if you start thinking about, yellow TheraBand or even red TheraBand. It's so light. Again, TheraBand depends on how hard you're pulling on it too. So there's that variable. But generally speaking, like I said earlier, you're probably not going to be able to generate enough force through that tendon in a TheraBand type of exercise, based on the fact that calf is already probably significantly atrophied just from being immobilized for 2 weeks.
Yeah, so you'll do both isometrics and then pretty low-level isotonics with the TheraBand, knowing that generally it's going to be self-restraining by just how much load they can place and how much they can really pull on that TheraBand. And then you can also layer that on, or you do layer that on with blood flow restriction as well.
I do.
Yeah. And from the early phase priorities, when do you decide, and maybe it's not during the early phase, but when do you decide, all right, they're strong enough, let's transition to a, maybe a donkey heel raise or a standing with some upper body support, kind of a weight-bearing standing heel raise variation?
That's a good question. I think a lot, unfortunately, depends on the surgeon you're working with too, right? Some of them have a little bit more strict guidelines as to what they really want and what they really don't want. So getting to know your surgeon is super important in this. For me, I think I really like to go to, have you seen the Baxter article, the Baxter 2021 article? And Josh Baxter and Karin Silbernagel did a really, really great paper where they rated the amount of basically almost like work, for lack of a better way to describe it, that the Achilles tendon undergoes, whether it be from the exercise's rate or the actual impulse from the exercise or the force from the exercise. And they basically tiered it into 4 different tiers, all the way from I think it was the first or the lowest exercise that stressed the Achilles tendon was a seated neutral to full plantar flexion bilateral calf raise, all the way to the most taxing, we'll say, as a total stress on the Achilles to a single leg forward hop. So looking at those exercises gives me a great idea as to how I progress. But in terms of when I start progressing, I think a lot will depend on, like we said, the surgeon. But when does the surgeon allow them to start transitioning out of the boot into a normal shoe with a heel lift? Again, as long as I'm significantly elevating their heels, my docs are usually pretty good with me starting some of that weight-bearing stuff, usually around the 4 week mark, especially if I'm got some upper extremity assistive devices, whether it be holding onto a table or using TRX straps, those type of things. I like to do that, probably within, the first 4 weeks. If I can initiate some of that stuff, I will. Really, again, just maintaining that plantar flex position. There are studies out there regarding early weight bearing that show there's no significant increase in risk of re-rupturing with weight bearing started at 4 weeks, before 4 weeks or after 4 weeks, as long as you're doing it in a safe manner with the heel kind of elevated and the foot in that resting plantar flex position. So again, I'm fairly comfortable starting with some partial weight bearing a little bit earlier than many, I think, in that position. But with regards to my exercises, I will progress to weight bearing maybe around the 4 week mark, depending again on the surgeon. And again, if they tell me, hey, Scott, I got a really crappy repair with this, be careful, then obviously I'm going to go a little slower versus, hey, you know what? This thing is solid. You're going to be fine with them. Young, healthy kid, non-smoker, wound looks great, 4 or 5 weeks, start doing some weight bearing stuff as long as their heel's elevated. Usually we start to progress them out of that elevation, into a sneaker by around the, 8-week mark, I'd say. I'd say would be a good guideline to say sneaker with elevated heel by 8 weeks, progressing out of it to maybe normal ambulation by 10, 11 weeks. But when I get them into a sneaker, sometimes I will get them back on the crutches if I need to, because again, I'm trying to promote normal weight bearing and normal walking, so I don't want them gimping around in their sneakers. I'd rather much have a normal heel toe progression with that elevation in the heel. And again, don't forget, not all shoes are created equal too. So just because you put a heel lift in a shoe doesn't mean it's the same as a heel lift in another shoe. So if you're putting somebody in a PEC shoe, which stands for pronation control elevated cushioned heel, which is like, a high traditional heel drop shoe, you've got a pretty 12, 14 millimeter heel drop or heel lift already built, or heel drop, heel lift, or however you want to classify it, built into the sneaker. And then you add, a little bit of a 2, 3, 4 millimeter wedge on top of that. Now you're talking about a significant lift versus somebody that's got a zero drop shoe with a heel lift in it. Very, very different. So be mindful of that. Not all heel lifts and all heel lift situations are created equal from that perspective. Did that answer your question?
That did. My takeaway from listening to you, listening to Peter Malieris, Eric Maida recently, people talking about these Achilles tendon repairs, there seems to be a consensus of why rush this early phase, and a strong nature of let's be a little bit more conservative with minimizing creep, minimizing this tendon elongation, having appropriate loading in the positions that are not increasing the risk of excessive dorsiflexion, and a remaining in wedges, obviously in the boot, but then in the shoes. Versus a lot of people feel like they need to or want to expedite this recovery process and get down as quickly as possible out of the boot, out of the crutches, out of a wedge. And that seems like doing more of a disservice to them. Maybe this is a good, you alluded to the example of the quarterback in the NFL, Aaron Rodgers, where maybe there is a little bit of an accelerated timeline for probably a variety of reasons. But how do you navigate some of those conversations, or what are the harms of rushing through these really foundational priorities?
Yeah, I think I think the thing we need to think about here is like weight bearing early is a good thing, in my opinion, based on the fact that I don't feel it puts the tendon at any early risk, while at the same time starts to stimulate some slight muscle activation that is helpful to help stiffen that tendon. Now, that being said, too much of anything good can be bad. So you've got to be mindful of that, and rushing some of these early stages are problematic. I'd much rather do the things in a very safe manner and get really, really good at them, as opposed to rushing through the cycles, which kind of alluded to what I was saying before. Like, get strong, because if you're really, really strong, you're more likely to be powerful. And if you're powerful, you're more likely to have reactive strength. That one builds on the other, and you can't have the top of the pyramid without having a good solid base. So I'm all about building a good foundation strength that's in a safe environment without trying to rush through these phases so fast. So that's probably my thing. Like there's moving through aspects of it that we can be more aggressive with that are still safe. We think that they're aggressive, but they're safe. Like weight bearing, to me, in a plantar flex position with crutches, gets a little bit of stimulation through that tissue, as opposed to casting them in plantar flexion and not letting them touch the ground, and that foot is just laying dormant for 6 weeks. To me, that's doing a disservice. Yes, you are creating maybe some healing, but are you maximizing the healing because you're not getting the blood flow through the tissue and you're not stimulating that collagen to start forming? Are you creating more atrophy, not only in the actual gastroc soleus, but there is other aspects of that tendon not getting the stimulus that it needs as well to be healthy. Other aspects of the foot, we often neglect that, right? Yeah, we're talking about the Achilles tendon, but what other tendons and small little muscles of the foot are being, neglected by being locked in this position of immobility and disuse for prolonged periods of time? So I think we've got to be smarter about being aggressively conservative or conservatively aggressive. How conservatively aggressive is probably the best way to say it. And don't rush through the phases. It's not how fast you can get through the phases. It's more time, but at the same time, building a good solid foundation that, if you get somebody too much range of motion too early, I often classify it as the toothpaste is out of the tube and there's no putting it back in. So if you've taken a surgically repaired tendon and preemptively or prematurely stretched it, you're not going to regain that stiffness to the level that it was before. So, be real mindful of that. You can always get somebody more motion later on. You're not going to really have a good chance of success gaining them a whole lot more stiffness in a creeped tendon, let's say. In the case of Aaron Rodgers, his world's a little bit different, right? He's an older quarterback in his 40s, early 40s. It was not his push leg. He had maybe 1 or 2, years maybe down in his career left, 2, 3 years, however he wants to, play, whatever it is. His role as a quarterback is much different now than it once was. And he might have said, you know what? Risk reward. I got to get back as quick as I can. If I lose a little bit of explosiveness, so be it. So I won't be as explosive. I don't need to be as explosive. It's not my push leg, my drive leg. I'm not a running quarterback. I just need to be fast enough and mobile enough to protect myself, right? So that would be very different than maybe how Lamar Jackson would handle his Achilles. God forbid he tears his, right? So I think you got to look at the age of the patient, what their needs are, what their sport is. In the example I talked about in one of the case studies, I had a gymnast. The good thing about gymnastics is they've got 4 different unique skills that they need to perform or activities, whether it be floor and vault versus bars and beam. So for me, with my Achilles patient that competes in all 4, we can talk about a return to sport on the bars a lot quicker than we can talk about a return to sport on the floor or on the vault, especially based on the demands of the Achilles and what it needs to do in those typical activities. So from a bars perspective, there's a couple of maneuvers that, maybe stress the Achilles a little bit. You got to get on the bar, and how you do that can vary. Some people use a little bit of a little spring to kind of jump up, and they can, in doing so, they don't need to be super aggressive with that. So they can put a lot more pressure on the good leg than the bad leg if they need to. But that's that. Sometimes there's skills called toes to bars, where they've got to get their toes kind of touching the bottom bar as they kind of swing around and go to the top bar. So that sometimes is a little bit of an awkward thing somebody coming back from an Achilles may deal with. And then lastly, and probably most important, just the landing, right? They've just got to be able to land. And landing on 2 feet is not that strenuous, especially if you start looking at, some of the demands of some of the skills in that Baxter article. It's not that demanding. Now, if somebody doesn't land well, that's the problem, right? So you've got to know your athlete. You've got to know, do they land short, chest over toes, or are they somebody that tends to land more extended based on the dismount that they're doing? I'd much rather have somebody land, especially after an Achilles, having their torso go back behind them, as opposed to have somebody where their head's going to come forward over their toes, get them into a more of an extreme dorsiflex position. But, based on that, you can start. I had my athletes swinging bars at like 8, 9 weeks, doing very, very minimal skills with her boot on, protecting it maximally, not doing any landings, just getting some of the easy skills back on the bars. When she would come off the bar, she would drop down very, very passively and land on her good leg without letting her injured leg touch the ground. And again, her coach was there. I was there. Her athletic trainer was there, making sure that the activities that she was progressing was very, very safe. But it was a gradual progression. We don't want an athlete going back at 6 months, which is what she did on the bars, never touching the bars until 5 months, let's say, because that's going to really prolong the actual return. But if we can do some skills and get them touching the bar and getting them engaged in safe activities and as part of the skill development before the actual Achilles and the foot and the repair has to be called into question, I think we're gonna get engagement of the athlete better. They're gonna feel a lot more, positive about the rehab experience. The coaches are gonna see, you just got to be mindful. Everyone's just got to be educated as to what you're doing, why you're doing it, and what the time frame is.
Yeah, I heard Eric Maida talk about this on the recent episode he was on with Noah on Ford Physio about Achilles tendon repairs, about basketball players getting them on the court as quickly as possible, even if they're just sitting in a chair, shooting hoops and eventually standing, but creating enough constraints to allow that person to not be at an increased risk, but put them in a position where they're back in the environment that they want to be in, that it's grading them and exposing them in an appropriate manner and doing the things that are safe and then building on those over time. So I'm glad you touched on that from a gymnastics example, but that can be from any athlete and their sport.
100%.
Yeah. Anything else with this early stage priorities, common mistakes, anything you want to touch on before we kind of shift into this mid phase of rehab?
Yeah, so I think what we've talked about is like early to maybe early mid. So yeah, early stage for me, like I break it down is just make sure the thing heals, it closes, and you could start to engage and really prevent as much atrophy as possible. That's what I'd say that the key is. Prevent atrophy and let it heal. Mid stage, I'd say, is where you start to really get more of the engagement of the muscles and you start really minimizing the amount of creep as much as possible and starting to build that foundational strength. That would be the mid stage for me. And the way I see the last stage is when you're really trying to maximize strength and work through the progression of, power, elasticity, explosiveness, and then the return to sport progression as that kind of goes along with it. So, whether you break it into three or four phases, the higher level strength progressing into return to sport or kind of grouping those together, it really doesn't matter to me how you kind of classify it, but that's kind of the balls that I like to put them in.
And for that transition from the boot to the sneaker, like you touched on, each shoe is built differently and understanding how much plantar flexion they'll be in, but also acknowledging that there should still be some support and then weaning that down over time. What is your general heuristic or timeline of they're going to be in a normal shoe? Obviously, there's variation of what that is, but when are they fully removing pretty much all of their wedges?
I think that's going to depend a little bit on how stiff they are. Somebody that's really, really stiff and struggling with dorsiflexion, I may take them out of that lift or lower the lift a little bit earlier to try to get a little bit more of that back. I still keep them in the lift, but maybe not keep them in the max. I think Eric and I differ a little bit here, and listen to Eric talk about it. He keeps them in that lift for a very, very, very long time. I don't necessarily keep them in that lift for, greater than, I'd say, 3 months. I'd say would be a good part for me to start transitioning them out of that. Maybe not a bad idea. And I've done this, like for my gymnast, for example, she was having a little bit of soreness. And she was spending sometimes towards the end, like where she was walking barefoot during practice and doing those type of things. I was like, well, when you're walking around campus, put your shoe on with the lift in so that we can actually rest it a little bit more, so that when you're actually spending as much time as you are without any type of footwear and your foot is truly flat, and you're stressing it more, it's not necessarily just over and over and over again beating that tissue and irritating it. So put her in the lift for the times when she needed it. So that's what I like to kind of go back and forth with. If somebody's really, really stiff and struggling, yeah, I'm not going to keep them in that lift for too long, versus somebody that's getting their motion back really, really easy. I might put them in it a little bit longer to try to stiffen them up a little bit too, right? So it's going to vary. And I think that's where the art of some of this comes in. Like, I hate protocols. I hate them. You have some guidelines and we know tissue healing timeframes, we know, and that's one of the reasons why I don't like to stretch somebody until about 5 or 6 months, because the tissue hasn't really plateaued in terms of its stiffness until after that sometimes. So it still has the capacity to kind of lengthen more than it necessarily needs to. But you make a progression, and how do they tolerate it? And then you make the next progression, the small step after that. And you kind of go down this path of how do they look? How do they feel? What's the next step? You don't run before you crawl. You make sure that each step along the way stresses the tendon maybe just a little bit more, so that you have a timeline of, okay, this person can probably start running at about, 16 weeks, give or take. Right? If they look like crap at 16 weeks, I'm going to hold them. I'm not going to let them run and jump. Right? And we could talk about, some of the things that you want to look for at that point. But if they're looking okay, maybe I'll let them run a week or two earlier than that 16 weeks. Maybe, depending on what do they need to do? What are they getting back to? Those type of things. We typically start plyometrics at like 14 weeks, typically. But it's not a hard and fast thing for me. Like, I might start some mini play, like what level of plyometrics are we talking about here, right? Are we talking about like plyometrics where you're kind of just doing a little bit of a rebound on the ground in a neutral ankle position versus a true bilateral hop in the air and land back down, right? So I think it's graded exposures, it's grading your stresses and making very logical small step progressions and then sitting back and seeing how your patient tolerates it.
With circling back or regressing to an individual eventually or finally get into a standing single leg heel raise and multiple single leg heel raises, what do you generally see as how long that takes? And I'm sure there is variation of a 90 or 100-pound gymnast versus a 250, 300-pound lineman, but are there times where you're like, all right, I'm concerned because this is taking a really long time for them to just lift that heel off the ground? What do you typically see as how long that takes?
So so I'm fortunate, and I'm going to say disfortunate, but fortunate. So I got on two occasions, two separate occasions. I've had gymnasts, but all four gymnasts, two of them tore their Achilles on the same day, at the same meet, had the same surgeon and the same therapist, me, and they progressed very differently, doing pretty much the same exercise and progression, along the course. So the second situation, two athletes tore it at the same meet, different surgeons, slightly different techniques, very, very different progression as to how they returned as well. Same therapist again, starting at about the 6-7 week mark. They had different therapists earlier on, we'll say, and different protocols early on too, in terms of what they were doing and what they were allowed to do and such. So that's always a challenge. But the cool one was really same surgeon, same tear, same day, same procedure, same therapist, responded extremely different with it. So that it just raises your eyebrows to say, wow, there are so many different factors that come into this, genetics being one. Like, I'm going to sit here and tell you that I, in my healthy stage, knock on wood, dream of having the type of calf and aesthetic calf and strength of a calf that one of my gymnast athletes has at like 7 months post-op. It was ridiculous. And the other one just struggled a little bit and still hasn't gotten the full calf girth back. Again, same exercises or similar exercises. So I think it just goes to show that there is some individuality with the rehab process and how you progress, and certain people respond to different types of loads, right? Some people like, heavy lower reps, whereas other people respond to maybe slightly lighter, higher reps. Just like certain runners do better low mileage and other runners do better high mileage. Everyone's not built the same. Everyone's tissue fiber type is not the same. Type 1, type 2 general makeups are probably consistent, but certain people's anatomy. Some people have longer tendons, right? Other people have shorter tendons. Where are their insertion points? What do they look like aesthetically? So there's all these different factors that come into play that make this very fun, but make it also not so much cookie cutter protocol driven, because you've got to keep in mind some of those other factors as well.
To that very interesting scenario of same team, same time they ruptured, same surgeon, same therapist, yourself, and one of them is improving at a quicker rate, it sounds like. Did you have to navigate some of those conversations with the other athlete as to why they aren't improving at the same rate? And I'm curious how those conversations went.
Yeah, they're tough, right? You're doing the right thing for the most part. You say basically at the end of the day, given the 12 months that this is probably going to take, at the end of the day, we're all going to probably end up at the same point at the same time, right? It just may take you a little bit longer or a little bit slower earlier on to get to that point. Then you're going to really kind of take off and move. Those are tough conversations. They are. It's like, why am I not responding like so and so? It's easier when there are different surgeons involved, because you do have, hey, your tissue damage may have been a little bit more, or, this procedure may have, been a little bit more, some of it's pain too. So in the case of one of them, they had a little bit more pain in there due to a speed bridge. And as a result of that, had a little bit more inhibition and a little bit more reluctance to kind of push as hard. So I think that factored into it a little bit too. So we're working on trying to minimize the soreness on the back of the heel. But in the case of where the athletes are the exact same surgeon, same therapist, same day. So time frames are exactly aligned. And one is just making, you got to start thinking other things like what are they doing outside of therapy? Are they spending more time on their feet versus the other person? I think that plays into it too. Are they taking care of it the same way when they're not in therapy? Are they icing? Are they elevating? And there's debates on ice and too, those type of things. But are they taking care of it? And are they managing their symptoms, as the other one is? But I think being on your feet for prolonged periods of time, getting to class as a student athlete is a challenge that we in the college setting kind of deal with some.
From a running standpoint, comparing to ACL reconstruction, there's a little bit more maybe of a consensus or ideas of the symmetry and the torque to body weight and just general quad and knee extensor capacity compared to the non-surgical limb. From a Achilles rehab standpoint, are there objective boundaries or ideas of there should be this type of force production or calf raise capacity compared to the non-surgical limb? Or is it kind of the wild, wild west of like, let's experiment and see how it feels? Or there's a little bit more wiggle room for an Achilles rehab compared to maybe an ACL?
Yeah, I'd say there's definitely more wiggle room, in my opinion. I think the standard testing with a lot of the ACL, literature, whether it be isokinetic testing on a Biodex or HUMAC or whatever it may be, you have those norms out there. It's very easy to get people in standard positions and test. When you start talking the Achilles, are you testing them? And I have a device in which it's like a dynamometer, but you test in a 90-90 position, and you can do side to side to see the symmetry index. You can do what is it relative to their body weight. But again, how much dorsiflexion are they in is really going to affect how strong they are. Are you doing it on a force plate where you're trying to do almost like a mid thigh pull into like a toe raise kind of situation with your knees straight or your knees bent, like whole host of different ways in which you can test. But so what I like to do is I like to look at bilateral comparison, where they are versus their other side, and just keep that as consistent as possible in terms of the testing setup. Can they do a single leg calf raise? I think is a big one. Can they hop in bilateral and single leg without any increase in pain or recurrence of symptoms? And how do they look when they're doing like a single leg hop in place? Because in my opinion, running is a plyometric activity. You don't have to be super, super powerful early on to start jogging. But you do have to have some capacity to load and explode. And then we're lucky in the sense that we have the ability to get people in things like the Alter G or the Boost, where you can kind of take them off their full body weight and really, tailor it down to maybe 60, 70, 75% of their body weight to start the progression, which seems to work really, really nicely, and to make sure that they tolerate that before you start getting overground running. To answer your question, I think it is more of the Wild Wild West. I think consistency and setup is key. I think there's a lot of different ways in which you can test, whether it be max strength, isometrically, isokinetically. You can test isokinetically on like a Biodex if you wanted to. People tend not to do that nearly as much. The setup is usually a bit of a pain in the neck, but you can. Dynamometry works great, whether it be with a push dynamometer. You can use a pull, the Tyndek, whatever it may be. However you set them up, you can do it, right? Force plates work great too. And then just be consistent. Sometimes symmetry, they start talking about, 90%. I think every place is going to have a little bit different, criteria as to what they use. I don't think 90% is really feasible to start jogging. I think I start them a little earlier than that, to be honest with you, especially if I'm starting them in the Alter G. But you want to make sure that they can at least do a single leg heel raise, and that they can at least, do a little bit of a hop and can tolerate that type of dynamic movement that's required of the skill that they're going to be doing.
You mentioned earlier that you're really not doing any specific dorsiflexion, range of motion, or end range loading or stretching for quite a while, till about the 5 to 6 month mark.
Static stretching. So I'll do like a heel tap. I'll do step ups, step downs, walking lunges. I'll do all that stuff, but I'm not going to put somebody on a slant board for a minute and say, hang out here and get your calf stretch. I'm not going to do that.
Yeah. Do you is that even necessary? Like if you're doing a deficit heel raise, step ups, lateral step downs, things that under load or forcing that dorsiflexion range of motion, does the passive stretching matter even? Is it?
I don't think so.
Yeah.
I don't think so. So again, I, I think those activities are super important for return to normal daily living. You got to go up and down a step, right? You've got to step on a curb. You've got to, walk, and you've got to do these type of things in your everyday. And we want to make sure, you don't have to start crazy either. A 4-inch step, progressing to a 6-inch step, have the surgical leg be your lead leg. The trail leg usually takes more stress. Same thing, stepping down, step down with the good leg, and then the injured leg. Walking lunges. I usually do a static lunge. The back leg is the leg in the lunge that's more stressed or more under duress. Gauge that a little bit. And then progress to a walking lunge, and then a walking lunge with weight. There's different types of isometrics, and people believe or don't believe in this, whether they're yielding, overcoming, static isometrics. I love isometrics. I'm a big believer in isometrics. I'm a big believer in being able to control deceleration. And I think that's a big component of return to sport following an Achilles or any type of tendon issue, is being able to absorb load and decel. I know Eric can't talk about the Achilles without talking about the knee and quad. So I listened to his episode, and of course he brings it to the quad, but the quad is super important too, right? So you just want to make sure that the whole system is working, right? You don't want to put somebody back in a situation where, yeah, great, you did a great job getting their Achilles, to be tolerant of load and decelerations and all that. But if their quad is atrophied because they haven't been doing those things, what risk are you putting that in? So you've got to be mindful of the entire athlete which allows you to get away with doing a lot more things. Like, again, when my athletes come in following an Achilles repair, they're tired even at the 3, 4, 5, 6 week mark doing therapy, because we're doing other things while being mindful of the actual repair. We're doing other things to load the rest of their body in a safe manner that, again, can prevent some of the atrophy and get them ready to do the things that they're going to need to do once the repair is at a level to take those loads.
Thank you for touching on that. And that is a consistent theme across a lot of these conversations, that people have typically 3 other limbs. They have a lot of options to remain as fit and strong and resilient as possible. And how can we keep them as doing as much training in a realistic manner as possible? And even that surgical limb or that, surgical leg, surgical arm, what can we do to still maintain some of those qualities, like you were saying with BFR and loading the quadriceps and the hamstring and the lateral hips? Like, that is huge across the rehab, and not just looking at someone as they're an Achilles tendon. I'm just focusing on their Achilles, and then it's 9 or 12 months later and they've deconditioned as a whole because they haven't consistently trained like an athlete and push themselves. And like you're saying, you can do that pretty early on when what are the constraints that need to be in place, but what are all the other opportunities we can take advantage of.
Yeah, that's exactly right. And we're fortunate, at a D1 school where each of our athletes has a strength, each team has a strength coach, right? So I like to get them involved with their team and with their strength coach as soon as I can, doing whatever they can that's safe. So for example, in an Achilles situation where they're non-weight bearing, we're going to let them do some seated upper body stuff, with their team and during those type of lifts. Obviously, there's a lot of communication that goes, that back and forth between the athletic trainer, between myself, between the strength coach, as to what the constraints and restraints are. But again, if I can get them doing stuff with their team, upper body wise, then that stuff I don't have to worry about, right? Like you're talking about, there's 3 other limbs. In most cases, I have to worry about the other limb, and oftentimes let the strength coach worry about the upper extremity, let's say, in a lot of these cases. But again, they're grabbing dumbbells, they're doing stuff with me to load the legs, so they're getting some of that anyway, right? So you've got to treat the athlete as a whole, and I'm glad you reinforced that.
This mid to late to return to sport, what are the things that you think are some common mistakes during these stages that maybe we haven't touched on, and really priorities you'd want the listeners and the clinicians to take away as they're preparing an athlete for the end stage and return to sport process?
I think you hit on it more so than I did. You hit on it early on. You said, why are we rushing through the stages, right? It's not a race to get to the end if you're rushing through it. Spend adequate time. My big thing is, again, I say the same thing over and over again. It's a little bit silly and repetitive in my mind, but it's get good at the easy stuff. The sexy stuff sells on Instagram, but get good at the easy stuff. 80% is really, if you can master the 80%, you're going to do very well as a physical therapist. And to me, during the late stages, if you haven't done a great job of getting them strong, then all this sexy stuff of all these cool agility, hopping, and explosive movements and change of direction, they're not going to maximize their potential if they don't have that good sound base. So I'd much rather spend a lot of time just isolating and getting them strong. Terminal plantar flexion rather, is critical and one of the hardest things I've found to get back. So that's something you really got to emphasize. But just get their calf strong, stimulate that calf in different environments, whether it be isometrically, whether it be concentrically, whether it be eccentrically, whether it be slow speeds, whether it be fast speeds, all these different ways in which you can load that gastrocsoleus complex is critical in preparation for sport. And then you can get sexier with all of the other plyometric power type of things that tends to do very well on Instagram posts. But it's important, don't get me wrong, you need to do that, but you need to get good, and the athlete needs to be well prepared to deal with the demands that you're going to place on it in a sporting activity, and it comes down to just getting them strong.
To that terminal plantar flexion that can be challenging to get to where it needs to be or to improve. We had years ago a conversation with Karin Silbernagel, and her going back to the quads from an quad perspective, her preference and bias is I want to load in this mid-range or kind of long, kind of stretched position, because that's where the most force is going to be. That's the most productive. I don't really care about loading and like terminal knee extension a ton because there's just not that much force. From a Achilles perspective, is it a little bit different of a thought process? As I want to spend obviously that mid-range and that loaded dorsiflexion, there's going to be a lot more load going into the Achilles and the calf, but spending specific time working on that plantar flexion at end range, terminal plantar flexion position, do you think that's more beneficial? And how do you go about implementing some of that?
I think they're equally beneficial. I think you got to do both. The problem with doing, and I do a lot of, like right now I have my athlete with the Achilles also doing some end range dorsiflexion holds. She's over a year out, holds, isometric maximum pushes into the ground in that full dorsiflex position. And then I'll have them do some reciprocal tib anterior work from that same position. Obviously they're not going to move because they should be at end range, but they're teaching their foot and their calf how to go from a stretch to a contraction to an antagonistic kind of movement in that same position, so that their brain is getting comfortable being uncomfortable at end range, or getting comfortable with being comfortable at end range, whether it be full plantar flexion or full dorsiflexion. I think I like to work both. The thing about plantar flexion is that it's safer to do earlier, and still that it's still a tough thing for people to get back. And I think one of the reasons it's tough to get back is because I think people tend to stretch out that tendon too much, and that creep is set in. And that's what you'll see, is that people don't have adequate plantar flexion strength at end range if that tendon is elongated prematurely.
Yeah, so some of that you may not realize until it's
Correct.
too late. Yeah, for
Correct.
Sure.
Yeah.
The
problem is people don't know that they've stretched the tendon out too long. Like they've been too aggressive, like because they come back, they feel good, the athlete's doing okay, but at the end of the day, they're probably not as powerful as they could be because they're a little bit. And you could test that end range plantar flexion, and that's going to be a good indicator as to how stiff they are. There are other things, and I think Eric talked about it in one of his talks. That resting position where you lay them prone, flex the knee. Where does the foot rest? Does it rest in a really plantar flex position, or does it rest a little bit higher in a more neutral position? So those type of things will indicate, what the resting tension of that Achilles is and that tendon is. But again, I think that terminal plantar flexion strength is a good indicator. If somebody's having a hard time getting that back, it may never come back.
The the risk of a re-injury or re-rupture to the Achilles tendon for both operative and non-operative is quite small compared to the example of an ACL reconstruction. I have a few questions. One, have you ever experienced a re-rupture, and do you have any kind of reflections on that experience or multiple experiences? And two, do you have any ideas why the risks or the rates are so much lower compared to an ACL?
So, knock on wood, um, I have not experienced a re-tear after one of my Achilles repairs that I've rehabbed. I think the rate is in a repair, it's somewhere between 3 and 5%, and I believe in a non-operative approach, it's upwards of maybe like 8 to 10. But no, I haven't, and I just must be fortunate. Maybe I should quit while I'm ahead and just kind of retire, right? But why that is, good question. I think the repairs are you're taking a piece of connective tissue that's got okay blood supply to it and bringing them together and allowing healing to kind of take place. I think that's one difference, let's say, than when you're taking an ACL and reconstructing it, let's say. And then I think you're also looking at some of the constraints too when you start talking about, early on the open repairs were really, really good. The re-tear rates were really low, I think, with the open rates, but you had this big surgical knot and there was just a big bunch of scar tissue there. But infection rates are higher and such. And then when you start talking about speed bridge and other bracing, not only do you have the repair, that's the mini open, we'll call it repair, and the internal bracing now also kind of adds a secondary repair to that. The forces you generate are high in the Achilles tendon. There's no denying that. I think you've got to look at the sports you're getting back into, and maybe it's that maybe the calves aren't super powerful enough. In that first year or two, while it's still kind of, quote unquote, healing, to generate enough force to kind of really kind of cause that re-rupture. I'm not 100% sure. I wish I knew why these things occur in the first place, because obviously there's a big, huge problem right now in professional sports and college sports for that matter, almost like a pandemic of Achilles repairs. And if I knew why that was the case, it would be amazing. But, I always tell my athletes, if you tore it once and it was a normal piece of tissue, you can tear it again after it's been, reconstructed or repaired. So, cross your fingers, live a good life, and hopefully pick your patients well. Just get them stronger and try to do the things to protect as best you can early on. And then again, go through the normal healing process, allow that to take place, and don't rush them back too fast too soon.
Anything else, Scott, with this entire rehab process that you want to touch on or summarize before we close things out?
No, I think, like I said, whenever I talk to my students about this type of situation, in most cases, Achilles repairs are fairly pain-free procedures post-operatively, which may be good and may be bad. If you think about it, pain is good because it slows people down sometimes. Pain is bad because it's annoying and sometimes can cause inhibition and weakness and those type of things. But generally speaking, there's not a whole lot of pain, especially if you don't have, in my opinion, any type of speed bridge. If you just have, like a PARS repair or something along those lines, they're pretty pain-free. And as a result of that, I think sometimes people tend to be a little bit too aggressive early on because they feel so good so early. So sometimes pulling them back, I think having them be aware of some of the limitations that they have and bringing that to their to the forefront and to their attention, I kind of can also slow them down a little bit too. Like, hey, listen, I know you feel good, but look, you can't get up on one toe, or you can't do a single like heel raise. I think sometimes that's eye-opening to the patients to let them know, hey, I might feel good, but I'm still not where I need to be and the things I need to do. So that's the other thing. But take home message for me is, limit infection, because if you don't limit infection, that wound doesn't close. The rest of the rehab is a total wash anyway. It's not going to matter because they're going to be in a whole host of problems and trouble moving forward. Second, like I always say, is again, try to maintain that tissue integrity as long as you can from a length tension relationship, from a creep perspective. And then lastly, don't rush through the phases of strengthening. Get them strong. Make sure you have a strong pardon the pun, strong foundation in strength before you start progressing through to being powerful and explosive and reactive and having that type of load and explode characteristics that is super important for sports and our athletic population. But again, if you get there fast without a good base of strength, they're not going to be good at it anyway. So might as well get them good at the basics and then progress them appropriately at the right time. And you're going to see a significant benefit and improved performance as it relates to that. Because at the end of the day, that's what it's all about, right? It's getting them back safe and healthy, but at a level of performance that they can go about their sport at the level, hopefully, that they were preoperatively, which again, may not occur in a 6-month window or a 12-month window, but you want to get them back there as quick as you can. And the way to do that is to have that good foundation and strength.
I think that is a perfect place to stop. Scott, this was great. Thank you so much for coming on. I'll link that the Baxter paper you're talking about, the Achilles Tendon Loading Index. Yeah, you've referred to that before, I think, in your Physio Network walkthrough and case study, which was helpful. Anything else you feel like would be beneficial for us to put in the show notes?
I think load different ways and different speeds, concentrically, eccentrically, isometrically, slow, fast. All of those different variables will teach the tendon and will train the tendon in a different capacity, whether it be, from a stiffness perspective to a more dynamic type of perspective. Our athletes need all of it, and we need to train them in different varieties and different fashions to prepare them for those type of movements that they're going to be doing.
Perfect. We'll call it there. Thanks again, Scott.
You bet. Thanks so much.